concern which the endocrinologist has to deal with is this expanding mass compressing the rest of the pituitary gland to cause gonadal failure, thyroid failure, or adrenal failure? Secondly, because this mass is situated centrally, does it cause any problems centrally? Does it impact vision? Does it cause headaches? Or does it invade locally, either east or west, or north or south? And then thirdly, if this mass is arising from the pituitary gland, will it cause over-secretion of any specific hormone? And there could be one of 5 hormones which are over-secreted. Hormones controlling fertility, hormones controlling the thyroid, TSH, hormones pertaining to prolactin secretion and breastfeeding, prolactin, a hormone called ACTH, which if it's over-secreted causes Cushing's disease, and the disease we're talking about, acromegaly, growth hormone over-secretion. So when the endocrinologist sees this patient, so this is a real patient with a pituitary tumor and acromegaly, and that is his endocrinologist, and this is the image of the tumor, again, the endocrinologist has to be concerned to treat pituitary compression by replacing any hormone deficiency, to shrink or make the central mass, to stop the headache, the local invasion, or the visual disturbance, and finally, to make sure that the hormone secretion is brought under control. And we have at our disposal some very effective surgical procedures, medical procedures, and radiation procedures. So there really is a 3-fold approach to treating patients with this disorder. And I want to emphasize, it is always benign. This is a benign mass which has caused its problems because of compression, because of local compression, and because of hormone hypersecretion. So what happens when the hormone is high? If you are exposed to high levels of growth hormone for many years, the heart is impacted, and patients may develop high blood pressure or hypertension, heart valve disease, or a disease called cardiomyopathy, which may, if it's not treated, lead to heart failure. Patients may develop headache or a cardiovascular event. They may develop gonadal dysfunction. Arthritis is a very, very common complaint of patients who have high levels of growth hormone. Colon polyps are commonly seen. Glucose intolerance and diabetes may develop. Respiratory complications and sleep apnea with or without snoring. So these are what we call the co-morbidities. These are the illnesses which occur in patients with acromegaly, and we can treat all of them and control all of them and cure most of them if we are able to block the high levels of growth hormone of the pituitary tumor. And not only can we treat those diseases, but we can actually normalize the bad mortality. So if the disease is untreated and the growth hormone remains high for decades, you have a higher mortality. And this is a wonderful study out of New Zealand 16 years ago, showing that if you look at the growth hormone levels at the last follow-up in a patient's chart, or the IGF-I levels, you can see if IGF-I levels are raised above 2 times normal, or if growth hormone levels are raised above 5, there is a poor mortality. However, if growth hormone is normalized on the left and IGF-I is normalized, there is no increased mortality. And this is a very, very important message for all patients. If your hormones are controlled, there should be no negative effect on the how long you are going to be living to a non-acromegaly population. So how do we achieve it? And this is an example of the tallest known man currently in clinical care. And this is an individual who's living in Uganda. And he has been very well controlled now for about 15 years. So how do we approach treating patients? And most of you know that the goals of treatment are to stop the morbidity, to stop the sickness, to reduce the mortality to absolutely normal, and to enhance quality of life. So your endocrinologist has to focus on these 3 goals when they are confronting a management plan for you. This have to be safe. We usually employ surgical resection. Sometimes, and we'll talk when, we may control your disease by radiotherapy, the RT, or we can control the growth hormone secretion and its action with treatment, with medication. And the strategy has to include a plan to preserve the pituitary function, those other hormones, the gonads, the adrenal gland, and the thyroid. And how do we assess patients? We assess them mainly by measuring age-adjusted IGF-I levels with the goal to normalize IGF-I, to control growth hormone hypersecretion, and to improve or even eliminate all those other diseases which I showed you which occur with high growth hormone levels. So these are the outcomes. And I love this chart because you can apply this to yourself. If you look on the left over here, going down along the left in the column, there are various markers of the disorder. Firstly, we have the growth hormone and IGF-I levels, blood pressure, yes or no diabetes, yes or no cardiovascular failure, yes or no arthritis, yes or no bone health, yes or no sleep disorders, yes or no quality of life, yes or no headache. And if you look at yourself over the years, in the green, the goal of an endocrine plan for all of these factors on the left is in the green to achieve long-term control over hours, days, weeks, and months. So the green is the ideal, and hopefully this will be achievable because it is achievable if we adhere to some of the principles which I will outline to you. At the other extreme on the top in the dark blue, some or all of these factors may be unchanged for decades. In the purple, some may improve for hours or days or weeks and then remain with disease persistence. Some very, very rarely will be controlled for a matter of months, and then suddenly, spontaneously, the disease will resolve. Unfortunately, this is not commonly observed. And then, very rarely, in about 10% of patients, the red occurs, that you may be controlled for hours for any of these factors, days, weeks, months, or even years, and then slowly, 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 the disorder recurs. So you can use this map to see where you fit with the goal for your endocrinologist to get you into the green. Long-term control of all the factors that you see on the left for hours, days, weeks, months, years, and I could extend this to decades. Because today, with all the wonderful tools we have available, there is no reason why you should not be in the green with long-term control. Let's understand the first principle, which is surgery. So you can see over here, this is an MRI of a patient with acromegaly, and you can see this small little a P-shaped island that my pointer is over. Can you see the pointer? And that pointer is over the small translucent islet, which is sitting here on the right-hand side of the screen, and this is secreting high levels of growth hormone. So this patient who is sent to surgery, because the tumor is nice and small, has a very high potential for a cure. The second concern which the surgeon has to have is, does the patient well enough for anesthesia and surgery? And if the answer is yes for both, this patient with what we call a microadenoma will be cured by the surgeon. However, this patient, the one that I showed you earlier, is a little bit different. This is a larger tumor, still benign, always benign. Growth hormone is 42 and IGF-I is 900, pretty high numbers. Is this patient a candidate for surgery? Yes, he's only 22 years old. The surgeon can really operate very effectively on this young patient. Is this tumor resectable? And the answer is probably not. So this tumor, even though the surgeon may go in successfully and take out 90 or even 95% of the tumor mass, 5% or less may be left, and that may be continue to secrete growth hormone. Does this patient exhibit tumor mass effects, those central compressive effects I spoke to you about earlier? And the answer is yes, because you can see over here this white rim on the top of the mass. Those are the nerves which lead to the eye. So this patient really does exhibit mass effects which are pressing on this, leading to the eye and may cause visual problems. So the surgeon will decompress this mass and prevent any adverse effects on vision. So people always ask me, what will determine the success of my surgery? And I can tell you that there is one main determinant of a successful surgery, and that is the experience of the neurosurgeon. Notice that I don't use the word skill, because they're all skilled. They're all board certified. However, the experience in how many pituitary surgeons does that surgeon undertake. And let me give you some examples which were published in 2003, but unfortunately are still true today. This is an example of several hundred hospitals in the USA, seeing how many pituitary surgeries they perform and the mortality from surgery. In the red, you can see that there are 20 hospitals in the USA, in the red on the right, who perform more than 25 pituitary surgeries a year, and their mortality rates are pretty low. However, on the left, you can see there are over 400 hospitals in the USA who only do 1 or 2 or 3 or 4 surgeries a year, and their mortality is double the hospitals who are 5, which is 1 every 2 weeks. So surgical experience is so important. Not only is it important for the hospital, it's important for the surgeons. 534 surgeons in the USA only do 1 pituitary surgery a year. And their mortality outcome very, very, almost 10 times higher than the negligible, almost zero mortality if the surgeon does more than 8 pituitary surgeries a year. And there are only 36 surgeons in the entire country who are doing more than 8. So I cannot emphasize the fact that for a successful surgery, if you're contemplating surgery or you are recommending surgery to any of your friends or acquaintances, and certainly in your support groups, surgical skill is the most important concern. How many, and the first question you have to ask that surgical center, how many pituitary surgeries do you do? And if you do a lot, you'll fall on the right-hand side, which is that you should have negligible mortality and your outcomes should be maximal. So the overall advantages of surgery are there's a rapid growth hormone decrease, there's a one-time cost, there is a potential cure if the tumor is small enough, and if it's not small enough, when you debulk or decompress the mass, you may enhance the success of subsequent added treatments. The disadvantages of surgery are that sometimes, especially with big tumors, the tumor may persist. You may get pituitary damage with pituitary failure, and not all people are appropriate candidates for anesthesia, and that'll depend upon your physical health. The risks of surgery are pretty small. Most of these complications are quite transient and occur within a couple of days or a couple of weeks and then disappear. The most important concern is to have a disease called diabetes insipidus, which leads to excessive urination, which occurs in about 10% of patients immediately after pituitary surgery. The rest of the risks are really negligible in a high quality pituitary surgical center, and mortality should be negligible. The more complications after surgery occurs if there's a low volume surgeon, and I want to overemphasize that. The low volume surgeon leads to more complications. And if you have bad comorbidities, like bad diabetes or bad high blood pressure or bad heart disease, in addition to acromegaly, or even unrelated to the acromegaly, that will add to complications. But overall, for most of the acromegaly patients, surgical outcomes are really quite optimistically good. So what about the next step? If surgery fails to control it, here's the example of how the surgeon goes in through your nasal sinuses and is able to resect the mass without having to operate on your skull. But what happens if the surgery fails to control high levels of growth hormone? Well, as you all know in this audience, because all of you have been very well educated, we have many drugs available. We have drugs which are the somatostatin receptor ligands, the SRLs, the Lanreotide, Pasireotide, and Octreotide, which act directly at the tumor over here on the big red X to block secretion of growth hormone by the tumor. We have dopamine agonists, which is Cabergoline, which is an oral medication, which unfortunately very rarely works, and we very rarely use it because it really doesn't work that well. And then we have the growth hormone receptor antagonist. The one that we have in the USA that's approved is Pegvisomant, which acts on the X over here at the bottom, which blocks growth hormone from acting on the liver to block IGF-I secretion. So in effect, your endocrinologist, when discussing plan of treatment with you, if you need medication, has at least 4 or 5 options to plan together with you. Lanreotide, which is the autogel, 60 to 120 milligrams every 4 to 6 weeks. Pasireotide, 40 to 60 milligrams every 4 weeks, or Octreotide, 10 to 40 milligrams every 4 weeks. These are all injections. Cabergoline is oral, but as I said, it rarely works well. And the growth hormone receptor antagonist, Pegvisomant, is given as a daily injection. These are your options. However, it's important to understand that all these treatments don't modify this underlying tumor. So you need to take the medication for the foreseeable future, for the rest of your life, to control the growth hormone. And each of these treatments requires very individualized titrations or combinations. And this is called a meta-analysis. When we looked at all the studies around the world ever published for somatostatin analogs, SRLs, how many people are successfully controlled? On the left for IGF-I and on the right for growth hormone. And you can see they're pretty parallel. So it doesn't really matter if your doctor is going to be measuring growth hormone or IGF-I, they're pretty parallel. We prefer IGF-I to be measured, but IGF-I is more stable in the bloodstream than growth hormone, so the measurement is more reliable. And what you want to do is you want to be on the top right-hand corner here. IGF-I normalization rates approaching 100%. You want to be in the top corner over here or over here, top right-hand corner. And remember, these are all the studies ever published all over the world, in big centers, in small centers, controlled studies, uncontrolled studies. And the overall response rate is that over half of patients, 55% of patients will have their IGF-1s controlled, and 55% will have their growth hormone controlled. Hopefully these on the bottom left are the older studies, and the curve would be shifted far more to the right now, that more and more patients are achieving 100% control if they are treated appropriately by their endocrinologist. And this is a very interesting study which came out of Italy last year, which showed that if you increase the dose to even higher than what the label says, not yet FDA approved. So for example, taking Lanreotide 180 milligrams every 4 weeks, or even increasing it to every 3 weeks instead of every 4 weeks. Again, this is not in the label, I want to emphasize. It's not FDA approved, but this was a study coming out of Italy showing that after 24 weeks, if you increase the dose to higher than what the label says, or you increase your frequency to every 3 weeks, you can achieve almost 100% control in every patient. And this was a very, very important study, which now allows us to do further studies and go back to the FDA and ask them to approve even these higher doses to give even better control to patients. So now, what is the difference between Octreotide and Autogel Lanreotide and Pasireotide, which is a newer somatostatin drug? So this is an example of the pituitary cell. There are 5 somatostatin receptors, and they've got easy names: 1, 2, 3, 4, and 5. And when you inject Lanreotide or Octreotide, you predominantly impact the second somatostatin receptor, SST2. And this is the receptor in the pituitary tumor which controls growth hormone. However, when you inject Pasireotide, you predominantly impact SST5, which is the 5th receptor. And this is also a receptor which controls growth hormone. So the targets of Lanreotide and Octreotide, Autogel and Octreotide, and the target of Pasireotide are different. Pasireotide targets primarily the 5th receptor, and Octreotide and Lanreotide the 2nd receptor. And so this gives a different profile in how a patient may respond. And this is the example of a recent study using Pasireotide, which is the newer one. Remember, this one targets the 5th receptor. This was an interesting trial. If you can look over here in the green, these are IGF-I levels in the green on the top in patients who are not controlled. These are baseline, 12 weeks, and 24 weeks. Over 24 weeks, the IGF-I levels remain high. These are patients who are uncontrolled on Octreotide or Lanreotide. But when you give these patients Pasireotide in the blue and the red, you can see their IGF-1s start normalizing in the green, in the blue and the red compared to the green. Their growth hormones start normalizing in the blue and the red compared to the green. So it appears that by changing the receptor subtype targeted in your tumor using a different drug, the doctor is able to achieve control using a different drug for the same disease. So some patients may respond better to Octreotide and Lanreotide if their tumor makes more SST2, but if your tumor is making more SST5, it's highly likely you'll be resistant to Octreotide or Lanreotide in the green, but you will respond to Pasireotide. So that's the difference, and you've probably been told by your doctor of these 3 different drugs which you could take for your disease. However, the problem with Pasireotide is that some of these patients may develop high levels of blood sugar. And so your blood sugar at the bottom has to be watched carefully if you're taking Pasireotide, even though it is superior to Octreotide and Lanreotide if you are resistant to Octreotide and Lanreotide. So the blood sugar should be watched carefully by your doctor. So let me summarize somatostatin treatment. This is an example of a patient with a big tumor. You can see this enormous pituitary tumor here, like a dumbbell, with these 2 black dots, which are the blood vessels in the middle. And you can see on the right-hand panel, and then going down to the left at the bottom, this tumor shrinks completely. This was a patient who responded beautifully to Octreotide. And this patient's tumor disappeared when the patient received Octreotide and continues to receive Octreotide. However, this is an ultrasound of the gallbladder. You can see these white spots in the black balloon area. These white spots are gallstones. So the side effects of using Octreotide long-term or Lanreotide or Pasireotide is you may develop gallstones. It's not a problem because usually these are not symptomatic and don't require any treatment, but you've got to be aware of it. So the advantages of somatostatin analogs are there's rapid control, there's no pituitary failure, and you can sometimes shrink the pituitary. About 50% of patients will have at least a 20% shrinkage of their mass on these drugs. You may develop gallstones, You may develop diarrhea or nausea and some abdominal discomfort. We've mentioned the blood sugar problems, so your doctor must watch your blood sugar carefully. And sinus bradycardia is a known side effect, but it's not a clinical problem, which means that your heart may slow down. This hasn't been seen over the decades to cause any problems, but your doctor must be aware that you will develop a slow pulse. And the other problems are that you may get injection site pain from the shots, and some of these drugs have been shown to cause headaches or alopecia, which means loss of hair. So overall, the advantages outweigh the disadvantages, but you've got to understand the disadvantages, which is that firstly, it's not a permanent cure. The drugs have to be taken for a long time. They are costly, and everybody has to deal with their own insurance reimbursements, and there are different plans for reimbursement. And most importantly, to date, until now, all these drugs require injection. So what about the growth hormone receptor antagonist? And the growth hormone receptor antagonist, or Pegvisomant, works on the liver. It doesn't work on the pituitary gland. And this is an example of the liver. The liver sees growth hormone over here. That's the growth hormone molecule. The liver sees growth hormone and manufactures IGF-I. In the green, you can see that the green drug blocks growth hormone action in the liver and therefore blocks IGF-I. So the growth hormone receptor antagonist Pegvisomant doesn't touch the pituitary tumor. It acts solely at the liver. The advantages are that this will normalize IGF-I, control symptoms, and works in more than 70% of patients if you take the injection every day. The disadvantages are it needs a daily injection. Rarely there may be a liver side effects, and very rarely the site of injection may develop what we call lipodystrophy, which means fatty deposits around the area where the injection is given. So Pegvisomant is a very effective. It doesn't work on the pituitary tumor. It works on the liver to block the adverse effects of growth hormone on the liver with a very high efficacy. More than 70% of patients will respond. And then what I call the apple-orange combination treatment. You can use both drugs together. And here's an example out of Rotterdam showing in the blue dots on top, uncontrolled IGF-I levels on monthly somatostatin. When you add Pegvisomant in a combination, in the red, you can see that all the IGF-1s dropped into the purple area, which is normal. So in this study, they normalized everybody, 100% normalization of IGF-1 when they added Pegvisomant to somatostatin. And there are lots of trials ongoing now in the USA testing the combination, the best combinations to achieve 100% control of patients on both drugs together. And it hasn't been approved by the FDA, but I strongly suspect that going forward, this will become the standard of care. And then phase 3 trials have been completed, and one has been published, and several have been published in abstract form, which now show the availability of an oral capsule which contains Octreotide. So instead of giving it by injection, the drug is able to be given orally, and this is absorbed in the gastrointestinal and in the blood circulation. The somatostatin enters the blood circulation and is able to work to suppress growth hormone and IGF-1. This has not been approved by the FDA, but the phase 3 trial has been published. And there is another oral drug which is also in earlier phases of development. So I think the future is bright for the development pipeline of as yet unapproved drugs for treatment of this disorder. And I want to give you an example of using drug only without surgery. This is a young man who came to see us in December of 2013. And you can see he had IGF-1 of 460 with an overbite of his teeth. And here is a tumor, large pituitary tumor, and we discussed with him the advantages and disadvantages of surgery. And he said to us, you know what, doctor, I don't want surgery. And we decided to give him injections of somatostatin only. And you can see he is a candidate for surgery because he's young and healthy. Is the tumor resectable? Probably not, because after surgery, he will require continued injection. Does the patient exhibit tumor mass effects? Yes. Like that other tumor, you can see it's touching the nerves which go to the eye. Did he consent to surgery? No. And this is an example of individualized therapy. He said, I don't want surgery under any circumstances. So we gave him the drug, somatostatin injection, and you can see in February of the following year, the tumor gets smaller. And by May, the tumor has virtually shrunk down to normal. And this is 2014, and we're now 2020, 6 years later. He still hasn't had surgery. So his decision for himself was correct. He had all the information. He weighed up the advantages. He weighed up the disadvantages. And he decided he's going to go for monthly injections. And that was his informed choice. So you can use drug only if there's a poor likelihood of surgical cure, if you're too frail to have surgery, or if there's an unacceptable anesthetic risk. The advantages are you may avoid non-curative surgery. And the medication must be personalized with you and your doctor in the discussion of what's the best approach for yourself. And then finally, we have another option. And I do it at the end because we very rarely use radiotherapy. There are some centers in Europe and in England who use radiotherapy far more commonly than we do. We don't recommend radiotherapy, although the advantages are that it's permanent. There are no long-term treatments required. There are no drug-related side effects. There's a one-time cost, and you're compliant because you go in, you have your therapy, and that's it. However, the disadvantages are it's very slow, it's often ineffective, it may lead to pituitary failure. Virtually everybody after 10 years will get pituitary failure as well because the radiation really affects the rest of their pituitary gland. There is some increased mortality, especially in numbers coming out of the UK. There is the cost of treating you medically while you're waiting for the radiation effect to kick in. There are some rare visual problems. Rarely, very rarely, especially with the older forms of radiotherapy, secondary brain tumors may develop with damage to your brain. These are very rarely encountered today. Radiotherapy is, in fact, much, much safer today than most of the reports in the literature, and this is improving by the year. However, the slow onset and the pituitary failure, the hypopituitarism, makes us not too keen to recommend this to our patients in the first opportunity. And then finally, besides all the medications, what we're most concerned about, and I know concerns you as a patient support group, what are all the other things that can go wrong that I have to have my endocrinologist treat successfully? There are joint pains, arthritis and headaches, heart failure, hypertension, high blood pressure, diabetes, sleep dysfunction, other hormone replacements. I need hormone replacement for osteoporosis. What happens if I want to become pregnant? The answer is yes, you can become pregnant, as long as you're appropriately managed. What about the anxiety of my self-image? Do I need surgery for my jaws to make my face improve cosmetically? These are very valid concerns for all of our patients, and the endocrinologist must be sensitive to be able to deal with all of these. How do I interpret this very complicated laboratory testing? The IGF-I levels, the growth hormone levels, using this lab, using that lab. Was my blood collected in the morning? Was it collected in the afternoon? Was it collected appropriately? Did the nurse mix up my testing with somebody else? These are very common questions. An interpretation of your lab testing is a very important component of what the content of the discussion that you've got to have with your endocrinologist. And most importantly, for all of you, whatever treatment you undertake, there will be some side effects, and those side effects have to be discussed with your treating, and your treating physician should be able to deal with everything on this slide. There is nothing here which cannot be successfully treated. This is not cancer. This is not life-threatening. This is a disorder which, if managed properly, can lead to optimal results. So let me summarize and end off with this slide. You start off your endocrine set. How do I target a management decision for my patient? The efficacy, the efficiency, the optimal care can either be surgical, it can be radiation, or it can be medical treatment. If it's medical treatment, the patient has to be maintained on the medical treatment. You can be switched between medical treatments to improve your success, and you can combine medical treatments. Not all of these combinations are FDA approved. Not all the maintenance and switches are FDA approved, but based on informed literature today, your endocrinologist should be able to discuss with you the information in the literature to be able for you and your endocrinologist to choose the best type of treatment for yourself. The side effects are very important. If you do develop side effects, you can always lower the dose. You can always switch treatments. You can always stop treatments. And the burden of one treatment may preclude using another treatment. And all this box tells you once again is that you have to have this open discussion with your endocrinologist, because using these tools, your endocrinologist will be able to minimize adverse events for you. And then, of course, there's cost. It's a financial cost, it's a social cost, and it's a personal cost. The most important cost is the value to you, the patient. How valuable is it to me as my quality of life improves to undergo 2 or 3 days of headache every month? How valuable is it to me to undergo the risk of getting diarrhea or abdominal discomfort for 3 or 4 days a month? That is your value choice. What is the cost to my doctor, to my hospital, and to my insurer, or to Medicare, or to the government agency? And that, unfortunately, has become a very important determinant in how you make that choice. And most importantly, what's the economic impact and the societal burden? I have to miss work every month to spend a day at the hospital registering for a simple injection. That's a cost. It's a cost for you to find parking. It's a cost for you to miss work. It's a cost for you to be away from your family. And these are disease burdens which we all have to weigh up. So this targeted management decision by you and by your doctor requires understanding all the positive, good things we can offer you. We can offer you outstanding surgery, outstanding radiation, super medicines, all of which have side effects, which we can deal with, all of which should come with a cost, and we make that value judgment with the goal of really providing you with the value that's going to optimize you to make sure that you have none of the side effects and that your life expectancy will be the same as a patient who does not have acromegaly. So Jill, I think I'm going to stop there and allow time for questions. And I think I pressed the stop share button, right?
You can leave it on that screen if you're okay.
Okay.
That's perfect. That's perfect.
Thank you.
So the first question, is it possible to know the relation between the tumor and the gland itself? A, is the tumor a separate entity growing into the gland and compressing the gland while expanding? B, tumor is surrounding the gland. C, tumor is growing within the gland. Or D, tumor may be considered intact and enlarged gland.
That's a great question. That's a very important question, and I tried to deal with it in the beginning and where we showed the MRI. The tumor is separate from the gland. It's like a small pea or a walnut growing inside the gland. And as this walnut expands, or as the pea expands, it squashes the rest of the normal gland against the bony sella. And that's what causes the pituitary failure. So if the surgeon can successfully remove that little walnut or the little pea, the rest of the gland will decompress and should have normal function. The tumor does not invade the gland. It is not an invasive cancer. It's a very well circumscribed, neat little package that's expanding within the normal gland. Great question. Thank you.
Okay. The second question, have there been any harmful effects for extended use of acromegaly medications?
Yes. Well, hopefully I've outlined some of them. The most important harmful effects for long-term treatment with somatostatin analogs are development of gallbladder disease, gallstones. Most of the time, they're completely asymptomatic and you don't have to worry. Very rarely, I think 1 in 100, you may develop inflammation of the gallbladder and you may require gallbladder surgery. But even if you do, thereafter, you just continue taking the drug. Actually, that side effect is very interesting in terms of your national and racial origin. In China, it is virtually unheard of to develop gallstones if you have acromegaly and take Octreotide or Lanreotide or Pasireotide. In China, everybody gets, it's the opposite. In China, everybody gets gallstones. In Italy, nobody, zero. And it may be the olive oil. The consumption of olive oil could be protected, but I'm not a gallbladder expert. But that's been the side effect, which has had a very, very interesting geographic and racial nuance, that you don't develop gallstones in Southern Europe. The other one is the slow heart rate, the bradycardia, which I mentioned. And then, of course, the most important side effects are if you're on a monthly injection, by the end of the month, the last few days of the month, a lot of patients complain of feeling bad. Their headache may come back, you start sweating, you start feeling a little bit yucky in your abdomen, your belly. And so that is a very, very significant side effect. And some patients actually take a quick shot of the short-acting somatostatin during the last few days of the month. Hopefully, the availability of an oral octreotide will be able to prevent that nadir of drug level occurring at the end of the month, because the oral has to be taken every day.
Great answer, thank you.
But I want to emphasize the oral has not been approved. So the only approved drugs we have are all injectable.
Can you explain acromegaly remission in layman's terms?
Remission means control or cure. The layman would say, am I okay? Am I okay? And the answer is yes. You should be okay. You should be in remission. If you're not in remission, go back to your endocrinologist and let them work it out, because the tools are there. It's a matter of marshalling all that information, of getting all the evidence, of speaking to the experts, of being able to integrate all that amazing amount of knowledge we have to focus individually on you, to maximally control you and put you into remission.
Do you recommend pausing medications following a certain amount of time that a patient has been stabilized, such as to prevent bradycardia as a side effect?
That's a very common question. Can I stop my drug and will the disease go away? And there was an uncontrolled study in Brazil, which showed that if you stop the medication, sometimes your hormone stays low for many months. We don't recommend that. There are other pituitary tumors like prolactinoma, for example. If you have a prolactinoma, a prolactin screening tumor, you can stop after a few years and it may go away. Unfortunately, for acromegaly or Cushing's or other tumor types, the treatment is open-ended. It's open-ended. Unless you have a surgical cure when you don't need a medication. But once you need a medication, I think you should reconcile yourself to the fact that it will be open-ended, and hopefully it will be maximally tolerated and maximally effective. but I would not recommend stopping a good thing.
Yeah. Has there been any progress in determining why or how this disorder develops? Are there any contributing factors or correlations with other factors?
That's an excellent question, which has put a lot of people's brains at work for decades, the last 20 or 30 years. A lot of people have spent a lot of time trying to understand why this disease occurs. And the challenge has been that it's not a cancer. So all that whole stuff of cancer research doesn't apply. And it's a very unique, benign mass. And there are, I would say, less than 5%, maybe even less, well, really low, certainly maybe less than 2% of the adult patients have a genetic cause, that they will have inherited it in their family. And there are patients with so-called familial acromegaly, and they may have some genetic markers, but these are very, very rare. Most of the patients with adult onset acromegaly have what we call spontaneous acromegaly. It just develops de novo, and we don't understand the exact cause. We have lots of theories, lots of hypotheses, but the exact initiating cause is unknown.
So my endocrinologist seems primarily concerned with the numbers and not my symptoms. While I can understand the rationale behind this, I do not want to have to wait until I have irreversible damage or changes to my face or body until my numbers increase to a diagnosable level. I have heard other stories of patients waiting years and then getting a diagnosis after many physical changes have already taken place. This is my fear, as I do not understand why my higher than normal levels are not considered in combination with my symptoms. Can you explain?
That's a very, very common patient concern, and it's one that should concern all of us as endocrinologists who treat patients with pituitary disorders. Quality of life, and that long list in the table of the non-IGF-I, non-growth hormone issues, the comorbidities, fertility, self-awareness, cosmetic surgery, how you're feeling, headache's very important, are all components of the treatment appropriately of patients with acromegaly. And one should not focus solely on the numbers. It's all very well telling a patient, well, your IGF-I is normal, you're okay, see you in 6 months' time. When in effect, you've got terrible headache, or you're perspiring, or you have colon polyps, which have not been attended to, or arthritis. So that's a very, very important question. And I would press my endocrinologists, I would press them to deal with those issues and not focus on the numbers. The converse is not true, because none of those issues would be maximally managed unless the IGF-I is controlled. So the endocrinologist is correct. They have to control the IGF-I. That is their primary focus. But once that is done, that is not the totality of the patient management. And the totality of patient management includes that long list in that table at the end of all the factors which concern a patient for their quality of life. Having a colonoscopy every 2 or 3 years, or as indicated by the colonoscopy findings, having a gallbladder scan, ultrasound of your gallbladder if you have pain in your upper right quadrant, making sure your diabetes is controlled if your blood sugar levels are high, making sure that your fertility concerns, your osteoporosis concerns are all taken care of. And now I want to come back to headache. I find in my experience, headache is the #1 complaint. When IGF-I is normal, I still have a headache. Why? What are you going to do about it? And that has got to be a very sensitive response by the endocrinologist.
I'd like to understand the mechanism of weight gain in acromegaly. What can we do as patients to stop the gain?
You know, That is a question which is, you're not going to like my answer. I can tell you now. There is no obesity in acromegaly. The one good thing about a growth hormone is growth hormone melts fat. If you're putting on weight, it is not from the acromegaly. It is something else. You're overeating, you're not exercising, you have a genetic propensity to obesity. There's something else going on, because obesity per se as a physical feature is not a feature of acromegaly. Big muscles, yes. Big organs, yes. Big bones, yes. Your weight may be high because of your bones may be larger, but not from obesity. And patients with obesity should not attribute their obesity to acromegaly. The opposite, I want to emphasize. Growth hormone, if you want it to be illegal and illicit and lose weight, inject growth hormone.
So can I ask you, we've seen several studies.
I told you wouldn't like the answer.
In acromegaly patients, ghrelin levels are high post-surgery. And weight gain is one of the largest complaints of our community post-surgery. And I'm just telling you what our thoughts are as a community, that the focus has been on growth hormone and IGF-I, but ghrelin is still high. And for us to do well as patients, all three of those need to be within the normal range in order for a patient to do well.
That's a very illuminating question. We're not sure that the ghrelin dysfunction after surgery persists for years. We don't know. We just don't know.
Okay.
And what you're describing may just be the effects of the acute surgery. What we do know is that immediately after surgery, most patients lose weight. And that weight loss is usually water. And for those of you who've undergone surgery, you will notice up to 5 pounds or maybe even more weight loss in the first 2 or 3 weeks after surgery. And it's usually water loss, excess water. And sometimes patients confuse water retention with obesity. And that may be one of the problems, because there may be water retention. I'm talking about the actual physical fatness of central obesity, which really is not a feature of high growth hormone levels. Mm-hmm. And if you look carefully in all the textbooks, obesity is not even listed as one of the features of acromegaly. But your question about ghrelin is very important, and that study should be done to see what happens to ghrelin dynamics 6 months or 2 or 3 years after surgery. It's a very interesting question. Thank you.
Well, I want to thank you, Dr. Melmed. I want to be cognizant of your time. And
my time's okay.
You know, I am so, as a community, we thank you so much for all that you have done for us. Literally, you have changed the lives of an entire community with your research and innovations. And we thank you for all of the work that you have done and for helping a community that most people have shunned over the history. And it really means the world to us. So I would also like to announce that next month, the first Sunday of the month, that Catherine Jonas is going to do talk about acromegaly and mental health. She's terrific. She's great. Yeah. So it will be the first Sunday of June, same time, same place. It'll be on the same schedule. So we hope that you all will join us for that also. So thanks again for your time, and we appreciate you so much. Be safe, everyone, and stay isolated. Thank you.